Trigger points. What are they and what can we do about it? Welcome to Learn to Run. My name is Dr. Matt Meinard. I'm a physical therapist that's passionate about helping you run smarter, safer, and faster. I want to put my physical therapy hat on today, talk about rehab, treatment. You've probably have heard of trigger points before. If you haven't, you'll learn. I want to talk about what are some options. I want to share a relevant and a recent research article where they looked at different strategies to try to address and to treat trigger points. I want to talk about dry needling, instrument-assisted soft tissue mobilization, but I also want to talk about different types of dry needling because it's super important. Where I've had people come in the clinics, dry needling didn't work for them, and we did it a different way, and voila, it's helpful and it works. So let's go over this. IASTM stands for instrument-assisted soft tissue mobilization versus dry needling of trigger points in long distance runners. Article out of 2024 that we'll include. But they asked the question, they wanted to see which intervention is more effective for pain and tightness. Pain, subjective reports of pain, and tightness or range of motion, particularly in the gastroc muscle of the calves. Zoom out, big picture, what fundamental or rundamental buckets are we going to be filling today? This is going to be addressing strength, range of motion, and injury when it comes to the running ecosystem, muscular strength, the length, and the integrity of the muscle. So let's go over some background information. Trigger points, what are they? A lot of times they're referred to as hyper-irritable, they're sensitive, taut bands in the muscle fibers. Muscles are a series of cells into tissues, into muscle fibers, which if you think of them, if we look at them under a microscope, they're striated. But ideally, if you think of it kind of like spaghetti strands, sometimes you'll get some strands that are clumped together. They're stuck. They're shortened because they're stuck. We call this a trigger point. One of our stupid jokes in the clinic will say is, you're so naughty. You're so naughty. It gets a laugh. It makes people less uncomfortable before we stab them with needles. But pretty much a trigger point is just a knot. It's a taut band in a muscle. It won't let go. It's hyper irritable. It's very sensitive to touch. If you think of a muscle fiber like a rope, this is one of the analogies that I'll use. If I have a knot within that rope, I can't stretch and pull and lengthen to release that knot. So that's a trigger point. And we have different strategies that we'll go over of how to release that. The other analogy I like to use, and this kind of ties into muscle versus tendon into the bone. If you think of a muscle belly or a bunch of fibers together, like a tennis net, all those individual squares are like muscle fibers. If I were to go up to the net, grab a fistful of squares, pull them taut together, then put a zip tie around it and lock it and walk away, that's essentially a trigger point, a knot, a small contraction in the muscle fiber that doesn't let go. And why also I like this analogy is if you think of that muscle belly like the net, as that net inserts into the cord, that cord-like structure, the cord being like the bone, that cord-like structure being like the tendon, we can affect how much tension is on that tendon or that cord by releasing the contractile unit or the muscle fiber. So those are two common analogies that I'll use when trying to explain what a knot or a trigger point is. So here's a little diagram of what a trigger point looks like under a microscope. Our goal, release and decrease. Release to try to help improve range of motion. Decrease to reduce the pain, the sensitivity. We have options. We have external options outside of the body to try to get to that muscle fiber, that knot. Or we have an internal approach, commonly dry needling, where we use a thin needle the size of a human hair to go into the skin, into the muscle, and try to massage and to release those knots. On the outside, there's many different strategies. I can use my hands. The biggest thing is that trigger points, they respond to sustained pressure, holding pressure, compression. That could be with my hands. It could be with a lacrosse ball. It could be with a foam roller. Thinking about surface area, foam roller is more broad. Lacrosse ball goes deeper. What are the different densities can all play into factor. How deep is this knot? How deep can we go? Merely what instrument-assisted soft tissue mobilization is just using some external device to try to release it. Back in the heyday, they used ribs and bones. It's been around for a very long time. You might have heard of the name Graston. That was a common brand name that kind of sieged the market for a long time. But now there's all sorts of the patents up. There's all sorts of other tools that you can get. I've even seen spoons, anything where it's considered a tool or an instrument falls under this category of instrument-assisted soft tissue mobilization. And this is where we're going. We're gliding along the skin and along the muscle to try to release it. So this is hot off the press. This is the study. Pathade et al., I believe that's how you say it, 2024. They did a study. They wanted to compare instrument-assisted soft tissue mobilization versus dry needling when it comes to trigger points in the calf muscles of long-distance runners. They wanted to see both what effects did it have on pain subjectively, but also objectively, of range of motion of that muscle. 40 participants, ages 18 to 25 years old, of marathon runners. They had to have these two criteria to be able to be accepted, included into the study. At least one active trigger point in the calf muscle. Practitioner searches, finds, that hurts, that's tight, that's tender, and lacking at least 10 degrees of ankle dorsiflexion range of motion. The calf muscle points the ankle down, plantar flex. If it's tight and restricted, it can limit the opposite direction when being lengthened into dorsiflexion. So what they do is they're going to measure that to see, one, does it feel like a trigger point? And two, is there actually a range of motion loss? And if they have these two criteria, they were included in the study. They took the 40 participants, they cut them in half. Not in half, but two groups, 20 and 20. 20 of them were in the instrument-assisted soft tissue mobilization group. 20 of them were in the dry needling group. These are the baselines that they looked at. They looked at their range of motion and pain. And how they measured this was range of motion. There's two common tests that we'll do in the clinic. The calf muscle is comprised of two main muscles, your gastrocnemius and your soleus muscle. Gastroc crosses the knee joint, soleus does not. So to get a better appreciation for each, we want to measure the folding of the ankle when the foot's on the ground, or ankle dorsiflexion, both with the knee straight and with the knee bent. So they did these two tests, they measured the angle, and then they did a pain pressure threshold test. This is very commonly done in research, where it's pretty much you've got this device that measures force, let's say in pounds, and we put it on the body or on the calf muscle or on the trigger point, and we keep increasing force and we say, hey subject, tell me when this turns from just pressure to actually pain. So as we're pushing, if it's really, really sensitive or painful, it doesn't take a whole lot of pressure before we start to say pain. So we get a baseline, we measure that. At what point, at what amount of pressure do they say pain versus just pressure? And so these are our baselines that we're going to measure, and then we're going to do our treatment, and then we're going to retest these baselines later on and compare. So here's the protocol. They did instrument-assisted soft tissue mobilization for 2 minutes. They went up and down the muscle, used the metal device. There's different techniques as far as which angle that they use, how much pressure. They didn't delve into that. My guess is they just used what was up to patient tolerance. And then they also included stretching of the calf muscles. 3 rounds, 30-second stretch, just like shown here in the picture. The other group did the dry needling. The way that they did the dry needling is they put the needles in, and they put them all around in the trigger points, and they left it in situ, they call it, for 10 minutes. They just kept it in. And then that group also stretched. So both groups are getting a separate, different intervention, instrument-assisted versus dry needling, but also both are stretching. Then comes the post-test, immediately afterwards. They looked at the range of motion of both groups, compared before and after. And then 48 hours later with the subjects, they redid the range of motion test again. And then now they measure for pain pressure threshold. Say, hey, does that hurt? When does that hurt? Now, how much force, how much pressure? So what were the results? What did they find? So in the instrument-assisted group, what they found as far as range of motion and pain, it improved all of them. Every single one, there was a statistically significant improvement in range of motion and pain. In the dry needling group, it didn't improve the range of motion, but it did improve the pain. And so you can ask yourself, well, was it just the stretching alone? Both groups did the stretching. Well, no, if that was the case, we would have seen a positive response in the range of motion in both instrument-assisted and the dry needling, but there wasn't. It was only in the instrument-assisted group that there was actually improvement in range of motion and pain pressure threshold. They could handle more force before pain, which is an indication of progress or improvement. As things heal and get more tissues become more normalized, they become less sensitive to touch and force and pressure, and vice versa. So what can we gather from this? What can we take from this study? The conclusion. So if instrument-assisted soft tissue mobilization, God, that's a mouthful. If that improves, plus stretching, improves pain and range of motion, then we incorporate it. Something you can do on your own, plus stretching. But if it's just range of motion you're seeking and pain is fine, then dry needling might not be your best option. But here's where we got to pump the brakes. The style of dry needling that they did is very different. I've been dry needling for a little over 10 years now. I was trained out of a company called MyoPain. The way that they do it, and a lot of practitioners do it, again, there's different ways to do it, same tool, same instrument, different uses, is very different. And I will say the patients that I've had over the years that have come in and they had this type of dry needling where they just put a lot in and they keep it there for a period of time and then they take it out and that's it, versus what we'll talk about in a minute here is pistoning. More uncomfortable what we do, but in my experience clinically and personally, a lot more effective. With the in situ, they put it in and they leave. And you're asking, yes, good question, what's the difference between acupuncture and this? Acupuncturists, the clinical reasoning of where they go is different than us. They use meridians and energy. We go based off of pain, anatomy, biomechanics. They tend to just stay into the skin for the most part, versus we go through that point down into the muscle. And then they keep it there for physical therapists that do this form of dry needling. Versus the way that I was trained, that I've been doing it for 10 years, is this pistoning. I'll put the needle in, and then I go in and out. I'm fly fishing, making sweet love to the muscle with the needle, fanning, searching, each time coming out of the muscle but not out of the skin, and then redirecting. And the whole point of this is to get what we call a twitch response, where when we hit that knot, it literally twitches, it releases. There's a lot of studies that show that what's happening is when we do hit that knot with the needle, it releases all these inflammatory markers, these muscle enzymes that are in our bloodstream when we're sore after exercise. Those are trapped in that knot. When we hit it, it's released, causes some soreness, but then we're able to actually get rid of it, improves the blood flow, affects the pH of the area, the length-tension relationship of the muscle. It's pretty incredible. I'm still impressed by how quick this can be effective. And there's not a lot that we do in PT where you're going to get these crazy immediate results, but this is our best tool, in my opinion. And again, this is just a tool. We have to go after what's causing this in the first place. But as far as treating the knots, treating the trigger points, trigger point dry needling is incredible. And I'm sure a lot of you can attest that you've had it. They tend to come from sustained positions or repetitive movements cause trigger points or the knots. Well, what is endurance sports? What is long distance running? Lots of repetitive movements. So we tend to get that. So here's my takeaway. Here's what I recommend. If you have a spot in your calf muscles, this localized spot that's tight, it's painful, it's tender to touch, you feel like it's affecting your range of motion, first on your own, try to stretch it out. Try not to just stretch it out, but first try to release that knot. You can use your hands to apply pressure, apply force to that knot. Hold 60 to 90 seconds. You can use a lacrosse ball. You can use an instrument-assisted soft tissue mobilization. You could use a wooden spoon. You could use a metal spoon. Put a little lotion on there, turn down the lights, get the music going, and just go across like you're scraping. Some people call this scraping, and go all the way across the muscle for 2 minutes. If that's not cutting it, if that's not doing it, then see if you can seek a physical therapist or some chiropractor or some practitioner that does dry needling, but ask what type of strategy they use. Do they do the pistoning? Do they do the massaging of the muscle, repeatedly moving the muscle, the needle within the muscle, or do they just put it in and leave it there? I strongly advise you to not do the latter. Try to seek someone that does the actual pistoning, dry needling. Myopain Seminars is who I was trained through, not a sponsor in any way. They do have a link that I'll put below where you can find a practitioner near you that's trained in this particular method and certified. And that's where if you ever see the abbreviations or the letters, the certification after someone's name, CMTPT, Certified Myofascial Trigger Point Physical Therapist. I know it's a mouthful, it's kind of messy, but they are trained in this style of dry needling. I hope this helps. If you're looking for other help, keep following along my social media, Learn to Run at YouTube and Instagram for all things running. If you're looking for training plans, mechanics help, information, I've got a Learn to Run club. If you're training for a military, I've got programs for you. And if you're a clinician, a provider, a physical therapist that's working on helping runners, I've got you covered as well. Thank you for being here. Questions, comments, concerns, please leave them below. I'll catch you next time.